as senior resident this institute, and I learned the nuances of glaucoma from Saruman and respected senior professor Ashok Sharma sir is there. So I'll be just now probably it's the last talk, right? So everybody's hungry. So I'll just skip through a few slides and be quick on this. It will be clinical updates in glaucoma management, and it's the fixing the adherence problem. And I'll be discussing about the importance of fixed combinations and their effects on patient compliance and cohort. So glaucoma, as by definition, is basically an optic neuropathy along with the visual field loss. So that's a very common slide, probably everyone must be aware of this. More than 90% of glaucoma cases in the country, they remain undiagnosed. And it's the third most common cause from blindness. It's a rapidly emerging non-communicable ocular disease in India. Just a brief overview of this. So patients' journey from the disease to commencement to the progression. So this is a whole, the cycle which every patient of glaucoma in your clinic, in my clinic, everywhere goes through. But I'll be just focusing on the highlighted part. The patients can't perceive the effect of the drops. So that's the most important thing, because patients, because they do not know what is happening to their eyes, they cannot. There's no vision improvement, so they stop putting the drops. Glaucoma is a web. It's a web of uncertainty. There are a lot of patients. It's not a disease which causes mortality, but it causes a severe form of disability. Patients who are on these are the patients who are actually on long-term medication. So their effect in the form of quality of life is quite tremendous, in the form of anxiety, depression, mobility disorders, pain, discomfort. So these are the patients actually who experience it. They actually know, if you've been attending the clinics in glaucoma unit. So if you keep on seeing these patients over years and years, then you will realize actually the patients are in real trouble. So it's been now 10 years almost that I've been looking after glaucoma, moving around multiple centers. So I see patients actually who are in this, who actually suffer from the poor quality of life. But my talk would be concentrated more on what is adherence, what is persistence, what is compliance. So this is a medical jargon. Normally, every one of us will be, talking to patients. You are not adhering to medicine. You are not persisting with the medicines. You are non-compliant. So this doesn't happen with glaucoma only. Any chronic disease for that matter, be it a thyroid disease or any diabetic retinopathy. Everybody whosoever needs a disease management, they have to adhere. What is adherence? So adherence is degree to which the patient follows the treatment instructions during a finite period of time. In simple words, adherence is whether the patient is adherent to whatever you are telling him. So for that period of time. So today you have told the patient that you put the drops, come tomorrow morning. So whether he is adhered to it or that is called adherence. That's not persistence. Persistence is if you see this patient 6 months down the lane, whether they are adhering to this prescription of yours for 6 months, that's called persistence. So both these terms are basically, they just cover the compliance part. So adherence and persistence, they are not to be used interchangeably. Poor glaucoma medication adherence, why it is important is because we can avoid this loss of vision if we just address this problem in these patients. What is the most common pattern of reporting of this adherence? In our country, it is self-reporting of the adherence. Patient walks into clinic, you ask, are you putting the drops? He says, yes, I'm putting the drops. So majority of times, you just have to believe the patient. So this what is white coat adherence? Patient puts a drop on the day of visit to the clinic. So his pressures will be fine. But in 6 months down the lane, you find out you have to be vigilant on this. You have to question him. Are you still putting the drops? Are you still putting the? They'll say, "Nee, 2 दिन पहले खत्म हो गई." So this is very common. This happens everywhere. So what you have to be vigilant is advancement of the visual field. So perimetry is very critical in these patients. If you see by any chance that there is a field progression, you have to be vigilant on this, because that's a sign of non-adherence. Patients who do not take their medicines as prescribed, they can be as high as 60%, not in glaucoma, everywhere in all chronic diseases, whether it's orthopedics or Crohn, or for that matter even cornea. Up to 50% of the patients, they stop taking medication within 6 months' time. So we all have encountered these patients. The most important factor in this probably would be if you see the healthcare system related. So that's a doctor-patient relationship, 14%. Lack of information about glaucoma, 22%. This is what we have to communicate. So 1/3 of these patients actually do not know what is happening to them. So as rightly pointed by Professor Mohit Gupta sir, communication is very important. These are the patients who you will be following maybe for a decade. Sir has followed them for 45 years. He has 95% compliance with the patient. Why? Because he's been effectively communicating. So that is a very highlighting point. You must communicate to the patient what are they being treated for. You are calling them again and again. Why are you calling them every 15 days? Why are you calling them 6 months time or month time or twice? Because they are paying for their visits, whether in the form of a consultation fee or their travel also. That includes the costs. So you have to educate them why are they being called upon again and again. So what are the various factors which actually make the patient not adhere to the therapy? So difficulty in the drop administration, poor self-efficacy, poor knowledge about the disease, cost of the medications, forgetfulness is there, side effects of the medicine is there, difficulty with medicine schedule. So if all these things affect us, even in reading the slide, so how much effect does this cause to the patient who is actually suffering from this day in and out? So what are the strategies to improve the compliance? We can reduce the number of medications, but actually the patient needs a better patient control, so we are giving him more medicines. So we can't reduce the number of medicines. So what we can do is, we can prefer fixed over unfixed combinations. We can select formulations which are better, softer to the eyes or in the form of a better pH. We can give the eyes which limits the exposure to the preservatives. So as sir said, even the patient of glaucoma, they actually land up with a lot of corneal problems. So we have to ensure that the drops which the patient is putting limits the exposure to the benzalkonium chlorides. So multiple medications, they decrease the adherence as high as 30 to 40% of the patients. They will not put the drops if they are prescribed multiple medications. And it's been seen that fixed combinations, patients, their adherence to the medicines improves. So if you give one vial of, say, brinzolamide, brimonidine, or separate 2 drops, the adherence is better with a fixed combination. But obviously we have to ensure the efficacy of the drug also. So these are the available fixed combinations, and it's not the latest brinzolamide, brimonidine. It's been there in the market for the last 4 or 5 years. Everyone of us has been using this medicine for quite a long time. So this is a comprehensive whatever is available, but the netrasudil is a rho kinase inhibitor along with the dinoprost combination. This is not available in India, but this is available in US. I'm sure this is going to land up in the market in a year or two times, because combination is the key. So this slide just highlights the various mechanisms, because whenever we are combining things, we must ensure the mechanism of action of the drugs, they do not overlap. So it has to be different. Only then they will, this summative effect will be there. So there are drugs which cause aqueous suppression, there are drugs which cause tubercular outflow increase, there are drugs which cause uvascular outflow increase, and there are drugs which decrease the epithelial expression. I'll add a few of these things. There are pharmacies available in US which actually formulate the drugs specific to the patient's needs. These are non-FDA approved drugs. So what do these pharmacies do? If I order them that the patient needs a combination of all the combinations which are available in our country, there are 2 drug combinations. So, right, it's brinzolamide, brimonidine, it's latanoprost, timolol, pilocarpine. But what we can tell the pharmacies in US, what some of the physicians do, though it is not approved, not FDA approved, they ask them to formulate drugs with brinzolamide, brimonidine, and say pilocarpine. So the doctor orders the pharmacy, they formulate the drugs. So for example, this is a company Imprimis. It not only formulates the combinations of glaucoma drugs, it formulates the combinations of tropicamide and phenylephrine also. This is available. But the cyclopentolate combination is not available in our country, so they formulate that also. So there are combinations, they are using, the doctors over there are using combinations of post-cataract surgery, a combination in the form of steroids and antibiotic and ketorolacs, or some of them with even bromphenics. Similarly, these are the anti-glaucoma drug combinations. There are 3 drugs, there are 4 drugs combinations which are available in the market in US, but these are non-FDA approved. So this is another company which gives these vials depending on the prescriptions tailor-made to the patient. So it's a 2 drug combination, 3 drug combination, or a 4 drug combination. So that how does this help? This reduces the toxicity, but the efficacy has to be ensured. So that is since it is non-FDA approved, so that efficacy of the drug is dependent on the physician who is treating the patient. Ocular comfort is the quality that glaucoma patients most desire in any IOP-lowering medicine. In a willingness to pay analysis, it was found that nearly 75% of the patients they would pay more for a medicine which is comfortable to the eyes, or the protocol of putting the drops is comfortable. So just to summarize, glaucoma is the leading cause of irreversible blindness. Poor adherence has been well documented. Adherence is critical because it will prevent an avoidable loss of vision. Fixed combinations are beneficial for glaucoma treatment as they improve the patient medication adherence. And the drop comfort upon installation affects the overall tolerability and a critical aspect in the treatment adherence. Thank you.
Thank you, Dr. Rajeev Jain, for excellent presentation and making us aware of something new also, that customized combinations can be prepared outside the country.
So their pharmacies, they call it compoundable. It's probably like initially we had pharmacies over here, probably in institutes in PGI over here, the pharmacists they can probably make drugs and they can put to use. For example, pilocarpine, and every one of us has faced this problem. Pilocarpine shortage was there. So people are using pilocarpine injections and putting them in the eyes for carrying out LIs. So I'm sure we people follow the dictums laid down by the companies. So probably our pharmacists, they are also the companies only. So we should probably more effectively utilizing the pharmacy, local pharmacy.
Our participants must be very tired, but if you have any question or anything, please do ask Dr. Rajeev Jain. Please. Well, I think as Dr. Rajeev Jain also told, Dr. Suresh Gupta also, Professor Suresh Gupta also told, Professor Amod Gupta gave us the best advice that it's not only important to acquire the knowledge, but it's also important to apply it properly. So you should know that art of communication, know how to even communicate the bad news. Those who are working in cornea or eye banking, they probably be knowing that how to get the donations by using that skill. I think with this, I hand over the mic to Professor Suresh Gupta for his comment.
So finally the program is over. So I do hope that most of the participants they were able to do at least 2 wet labs of their choice, and I hope all of you learned at least something in last 2 days. And anybody who was not able to do wet lab of his choice, so we are planning another program in the month of December. So those candidates will get priority during that program. And I think the carry home message from me to all of you is, whatever you have learned during these 2 days, you have to apply it to your daily practice. If you just learn the things for this program, and whenever you come back for another program, then you get reminded of those things, then it's of no use. So whatever you have learned, there's so many speakers of the top level. Professor Amod Gupta, he is a teacher of teachers and one of the best speaker in the world. So whatever we have learned, we have to apply it to our daily clinical practice. Like you see a patient, so you have been taught a topic, you see a patient of thyroid or thyroidopathy. So whatever you have learned, try to apply it clinically in that patient and make it a routine. So when you try to apply that knowledge to that patient, so then over a period of time it will become reflex, and then you will be subconsciously using that technique or examination, and that knowledge will help you in becoming a good practitioner. So, and then I am also grateful to all of your head of departments. So please convey my gratitude to them. It's only because of their involvement that we are able to organize this program. So with this, I think I am again grateful to all of you for participating in this program. So thank you very much.